I think we have a bit of time now for some discussion about both of these really good programs. I actually have a question for you, Vanna. How is your program funded?
Well, it's funded from a grant that we have, from grants that we have from pharmaceutical companies. It's really hard to attract money from the government at this time point. But of course, treatment is provided free by the government.
I do think it's just it's an issue worth discussing, and I'd be interested to hear people's thoughts on this. But one of the challenges, we see these very nice demonstration projects, which are often funded by pharma. In somewhere like Iceland, the demonstration project might actually be the final project, but that's not true for most places. And how do you scale things? How do you then take something that works very well, but is funded in a temporary way, and then make it more sustainable to try to scale it to the whole country? So I don't know if you, like, what's your plan for?
Well, the truth is, it's an existing, it's a true danger, because we had a similar program during the outbreak of HIV infection, and it worked very well for 2 years. We had secured money from the European Union and some local funding. And after that, when it ended, there was nothing provided to drug users. I mean, they tend to return to the study site, and they couldn't find us anymore. So it was a bit disappointing. And now we start again, but we are very unsure about the future.
I can say, regarding to funding, obviously, regarding access to DAAs, the prices are now coming down, and I expect that we, in Iceland, for example, we will have continued access to DAAs through the National Health Insurance, and other services are covered by the National Health Insurance, and they are provided free. And that has been so and will remain so in the future. So I don't think we will have a problem with continued funding. I don't expect.
But also there are some, the good news is that there is intention to cover the cost of HIV genotype testing. And now that fibrosis restrictions are removed, perhaps it's not that urgent. There is a patient association providing for free fibrosis evaluation. So I think we can cover all the costs related to test and treat. So it remains just to try to attract the population of active drug users, which is not that expensive, I think.
Thank you both. Great work. For Sigurður, on one of your slides, you mentioned the possibility of needle syringe programs in prison. What's the status of that? Well,
we are working on that. I would like to see a needle syringe program within the prison system. And but they have been sort of resistant yet. And but thankfully, we haven't seen any reinfections within the prison system. As I mentioned, one way to approach this is to try to treat, if you are in a given prison, to try to treat most of the infected inmates at the same time to reduce the chance of that's what we did. And we haven't had reinfections within the prison system, but I think we will get NSP within the prisons. I think that's important.
That's encouraging. And then all men and women who enter the prison system are screened for HCV, HIV?
HIV, Hep B.
Great, thanks.
John?
That was mine. Good morning. Sigurður, that was a great presentation. That's really a great program y'all put together in Iceland. I've really enjoyed reading about it and now hearing about it. I'm curious, though. I've really become a believer in goals. That's the whole purpose of having elimination programs, or those goals. What's the end goal for the program? I mean, you've seen really impressive reductions in RNA positivity, so that's a great index of your elimination. Are you really striving to have 0 cases in an island population? Or are you looking at a 90% reduction? What's your end goal, please?
Well, we have sort of looked at the World Health Organization goal of 80%. Well, actually, that's 80% for, I think, isn't it, for hepatitis C? And well, I think it's going to be difficult to totally eliminate, even in a small island population, because first of all, we have this intravenous drug use population, and even if we did not have any imported disease, it would still be difficult. So, but we'll see what happens. And then we have this a wave of asylum seekers from countries where hepatitis C is much more common than in Iceland. So it's important to screen these individuals. And if they remain in the country, and we keep track of that, we collaborate with immigration officials, the authorities, to make sure we know of every asylum seeker that is granted immigration status, so we can offer them treatment.
Mm-hmm.
So I don't think it's realistic to get it down to a zero, even in an island population such as in Iceland.
Well, we speak of measles elimination in the Americas, but, and then you still get importations from other parts of the world, but you still consider it eliminated in that area. So, like I said, I think I'd be interested in having an end goal, and maybe your end goal could be
it's 80%.
elimination.
We aim for 80 or 90% reduction in incidence.
Right.
When we will achieve that, there was a modeling paper published in Journal of Hepatology earlier this year suggesting, in collaboration with Margaret Hellett and Nick Scott from Melbourne, suggesting that if we increased harm reduction and intensified testing, we could potentially achieve this goal by 2020. And we've already, I think we are close to achieving the World Health Organization service coverage targets. We are close there. But whether that will translate into the elimination goals, that remains to be seen.
Mm-hmm. It's good to be talking about those metrics. Thank you.
Hi, I was wondering about the MSM community. You said you hadn't seen an outbreak there yet. I wonder, are they being screened regularly? How are you keeping track of that? And especially because in Sweden, for example, for HIV, I think there's very little HIV transmission in Sweden, but people go to Berlin and maybe also Amsterdam, and that's where people get infected. So I'm imagining Iceland might have a similar traveling community.
Well, we collaborate with the gay community, HIV or patient association. And so we have had outreach screening sessions where a lot of people attend, or a quick point of care testing. So we are reaching out to this patient population. Not yet on a regular basis, but that will happen.
Can I just ask you a question? When you showed the numbers of people tested and it's clearly increased, do you have a sense of what percentage of the population's been tested over the whole population?
No, I don't. Mostly we have tested patients that have some kind of a risk factor. So there was there's evidence that there was a late introduction of hepatitis C into Iceland after 1980, and IV drug use was almost unheard of before 1980-85. That's where we started to see that problem. So, but I don't have the sense. A lot of these tests are done on patients with most risk factors, I think.
Where are the microphones? We'll follow the mics. So.
Thanks, Sigurdur. If you were to sort of think about, so 2 questions. When people are coming into prison, how soon after entrance into prison are you able to offer a test, and thinking of sort of like, is it at entry, or say in Australia we have a delay and we're trying to work out how to reduce that delay in coming into our prisons? And the second thing is, when you reflect back on setting up the program, I think you're discussing it in 2014, 2015, what do you think was the hardest couple of things that had to be done to convince either your Ministry of Health for some funding, or what were the things that you think were the most challenging and the ways you got around addressing them?
Well, I think in the beginning, the convincing healthcare authorities of funding obviously made it easier for us to sell this idea of elimination of hepatitis C when we had the drugs for free at the beginning. And I think that helped quite a little bit. Also, the idea for politicians also, it's very, to have the idea of eliminating a disease, that's a very good selling point. But getting the authorities on board, I think that was although it was not a major challenge, that was one of the main challenges. And I really, there were not that many challenges, to tell you the truth, in the beginning. I don't think so. And the second, the question about well, we try to do this preferably within a week or 2 weeks, and we actually, our nurses, they go out there and do the screening themselves, but we're going to install a program where all the prisoners are tested the day or a few days after they arrive.
Is testing voluntary for prisoners and asylum seekers?
Pardon?
Or is testing voluntary?
For us, no. If you come from, if you are seek immigration status or asylum seekers from outside the European Union, screening is obligatory. And I think that's very important.
Thank you. Those are all three excellent presentations, very informative. I'm new to this whole elimination process, but one of the things I don't hear enough about here, which I do in other disease domain, is antimicrobial resistance and monitoring of it. And I'm just wondering, are these not really concerns even in your environments where you might have some loss to follow-up in patients who might not, be able to complete their treatments? Is the emergence of resistance to any of these DAAs not really a significant issue? And if it is, are there monitoring systems that you have in place in your settings that are really looking for these patients and trying to determine what the different patterns might be emerging and what we might do with it?
Obviously, that has been a concern. For people in complete treatment, it's been a concern, and that we would be left with resistant strains spreading in our country. But we do for patients who do not respond to treatment, we do deep sequencing. But so far, with patients that we have had no problems with the second treatment, even if the first treatment was not successful or they didn't complete the treatment. Usually the second treatment is very successful, and so we have no problem so far with resistance. There are only a handful of patients that we have to treat with different regimen, like Sofwell-Vox. But we are monitoring this.
Just to follow up on it, there is sort of a global effort called the SHARE program, which is registries from around the world combining their resistance data. So labs that are doing resistance testing, there's many European countries, Canada, the US, a number of other countries around the world that are putting their data together to look at resistance patterns. And I think really to your point, among people who have not been treated. So looking at transmission of resistant virus, because we haven't seen as much of that as people feared we might. In terms of retreating individuals, that hasn't really been a big problem, but the question is whether we'll see transmission among networks of people who are using drugs and things, and so far it hasn't seemed to be a big issue, but it's certainly something that needs to be followed.
Great. In Iceland, can you say a bit more about how you're going to assess the impact on mortality of the program?
Well, we have, in terms of hepatocellular carcinoma, we have a cancer registry for the whole country, dating back many, many, many years. So we'll continue to monitor that. We will also prospectively following new diagnosis of cirrhosis in the whole country. We actually have very detailed data on all new diagnoses of cirrhosis in the country. And so we'll keep continuing very detailed. So we'll have very few patients with cirrhosis will escape our system, surveillance system.
Can I ask you a question? Have I liked your approach of getting people into care with the incentives and having people go out and get others. Have you looked at actually peer testing, so having them do the tests themselves and then bring back people who test positive, rather than having them all come to the site?
No. It works. I don't know if I. It works quite well as it is. We are not that much worried about the testing part and the screening part. We are more worried about the linking to care because the first part works quite well.
So your sense is that most people are willing to show up for that first visit?
Yes.
You, at least two of you spoke about the FibroScan and using that to distinguish who at the earlier stage of the programs might get onto treatment. And with the numbers that you're dealing with, they aren't, they're large, but they're not on the scale that Manuel was speaking about. Do you see the role of separating out patients based on a FibroScan cutoff in some of these mass screening programs where you might, Egypt had the resources to offer treatment to everybody who is RNA positive, but in the instance when you don't, is that a good approach potentially to approach, to prioritize those people who might have a more chronic disease based on even a FibroScan setting in some of these mass screening settings?
Well, in our case, when we are trying to reach a target of numbers to treat, we really need to attract as many people as possible because we cannot reach our targets. We have agreed to provide treatment for 5,000 people in 20 months in Greece, and we are still behind that target.
So irrespective of the result, you're now treating everybody. That I understand.
That's why we removed the restriction.
But what do you guys think if in other environments where we don't have the drugs to treat everybody that is RNA positive, what might be the best way to prioritize some patients versus others?
I mean, people have looked at this. There's been a number of studies that have evaluated this way, at least from a modeling approach, what's the best way to prioritize if you have to prioritize. And at least from a cost effectiveness standpoint, what usually comes out in most of in the studies is that prioritizing those with cirrhosis is the first group to treat, and then second group to treat are people who inject drugs because of the prevention benefit. I think most countries that have instituted some type of fibrosis restriction have usually used F2 fibrosis as the threshold for treatment. That's not really particularly evidence-based. It's mostly a holdover from the interferon era when people would argue that if someone had at least stage 2 fibrosis, you could justify the use of a miserable treatment with a low efficacy. But I'm not sure it's actually really an evidence-based strategy. Margaret, I don't know if you want to speak to that because you've done some of this modeling.
I mean, I think actually, and it's depending, and this is where you can be totally cold-hearted and whatever, it's where transmission's occurring that you get your most cost-effective. The reality is that countries shouldn't let people die, so they will treat stage 4. But if you were really being totally hard-nosed about it, depending on what people were doing, you'd say you actually treat where transmission is, but that's just not an appropriate thing to do. So countries, when you look at the cost, you'd treat at that end, and at wherever transmission is occurring with the epidemics. There's no evidence. Natasha and Martin, Peter Vickerman and Matt Hickman's work early on was showing that stage 2 thing was a leftover from the past, and our work would suggest that as well. So, yes, but you can't just not treat people with significant liver disease, even though I think some of Matt and Natasha and Matt's work and those was that actually it was cheaper to just treat where transmission was occurring because... So I would say if you had to really prioritise, and I really am against prioritisation because I think these drugs are now cheap, and I don't think that's where the cost comes into programs. I think the cost comes into programs in other areas where you actually need to be having people out doing testing, you need to have people out doing health system strengthening. If you sort of look at Georgian colleagues, I'm not sure, they would say that a lot of it is to do with their health system strengthening, and those things are your costs, not the cost of the actual treatments itself. And I mean, Manal, you might have something to say about that.
Yeah, I agree. It's the cost goes to something else, not the treatment. It's always about also the human resources, the capacity building. We have huge teams, numbers and thousands who are working to just implement the screening program in Egypt. And I think it's all about just the system and building up the infrastructure and the system and the applications and the internet and the database. It's not the cost of treatment. I agree with you.
I think we're actually, sorry, Yvonne, go ahead.
Just, there were a number of questions that pointed to costs. I just want to mention that at WHO we've conducted a price tag estimate for the cost of elimination in the world, which is now a manuscript that's going to be submitted for publication. So it's not ready to be shared now as a PowerPoint, but what we found is that if we place elimination in the context of universal health coverage, the incremental cost is about 1.5% of the total ambitious UHC attainment scenario. But maybe one of the most, so it's not a small amount of money, but it's really something that can be considered. But maybe one of the most interesting conclusion that we found is that actually for 1.5% additional investment, the benefit that you gain in terms of mortality reduction, in mortality reduction is multiplied by 5, and in terms of DALYs multiplied by 10. So what we learned after this is using a methodology that really compared with the rest of UHC intervention, is that compared with a lot of things that are being proposed in the context of UHC, we're very high impact intervention. So that's one of the way that we're going to try to spin it to advocate for national financing. In terms of prioritization, Amir, frankly, in Pakistan, no prioritization. You have some of the cheapest DA on the planet, so I think anybody identified must be treated.
Well, we're actually, just in trying to keep on time with our schedule, we're the way it is now, 9:45, I think, so we're going to move on.